I welcome Dr. MVS Satyaprakash sir, who is a professor
to deliver the CME talk on the drug errors in anesthesia.
Sajeesh, he is a HOD senior consultant at Department of Anesthesia, near MedCity Hospital, Trivandrum. He has a vast experience, around 26 years in anesthesia and clinical practice. He is a lead faculty and coordinator, 6-month-long, head-to-foot nerve stimulator plus ultrasound-guided nerve block and pain medicine, online symposium course organized by ICET Trivandrum City branch. He has been director 2 weeks USG RA fellowship programs. He has held many posts, to name a few: past president ISA Kerala State Chapter, scientific committee convener IMA National Conference 2002, organizing secretary AORA 2018, organizing chairperson ISA Kerala State Conference 2022 and 2023. Over to you, sir.
Thank you, Dr. Krishna. My friend has just delivered an excellent talk on pediatric, children brain development and all. My talk is on, even if we are given a normal anesthesia, there is a lot of problems on developmental brain in children. But what happens if we give a mishaps happen? Error of one moment becomes a sorrow for all life. It's not only for the patient, but for us also. The problem is that a few mishaps in entire my career is still haunting me. Even if I am standing here on the podium, still haunting a few patients, their full name and details is running with me. I'm sure most of the seniors here will agree with the same thing. So drug error is, the reporting of the drug error is on the only tip of an iceberg. Only a fool learns from his own mistakes. The wise men learn from the mistakes of others. I invite all the wise men and women to learn something from our mistakes. So I start with a case. A few years back, we had a patient, a 20-year-old male for a pyloric stenosis. And I am fully aware of the fact that he is only 2.3 kg, and fully aware of the fact that the problems, drug dosage problems will be there in the OT. So I made a beautiful, full elaborated list of the anticipated drugs and the dosage and everything. And in the morning, we started the case. We ultrasound guidedly, we decompressed the stomach and started the anesthesia. Everything went well, surgery went well, everything. But the problem is that we decided the post-op analgesia to give a tap or a rectus sheath block with the ultrasound guided 1 or 2 or 3 ml of this thing, everything we planned. Along with I planned to give a paracetamol IV. 7.5 milligram per kg, and the total dose will be calculated, it will be around 17.25 milligram. But the problem is that I missed to mention the IV paracetamol dose. I give an instruction. I have forwarded on WhatsApp to my technicians and my colleagues, but I forget to mention about the paracetamol dosage. And what happened is that I ordered them to give 17.25 milligram, around 17 milligram of paracetamol. They give 17 ml of paracetamol. The literature says that around 200 milligram per kg is a young child is got a good liver functioning, around 200 milligram per kg tolerable and all. For the last few years, nothing happened, but terrible mishap. So it's a big medication error. Any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in control of the healthcare professional or patient or consumer. And this is a National Coordination Council for Medication Error and Prevention definition. I'm quoting some of these, some of the guidelines and references from ISMP, that is the Institute of Safe Medication Practices. And those who are interested, there's a beautiful guidelines there on their website. Of course, a few WHO guidelines, and 2-year is a human is another, is a landmarks report on from 2000 from USA regarding the drug safety. And of course, a few cited from the BJA and our IJA. from age old, we are discussing about the aviation, in comparing our aviation industry with our anesthesia. Is it safe? Its aviation industry is safe as far as mortality is concerned. It's around 1 in 8 million. That means to get you in a terrible fatal mishaps, you have to travel round the clock for 80 years. That is very unlikely you get in a very mishap in the entire your 100 years lifetime. So what's the matter in our anesthesia? Our anesthesia also is much more safer nowadays. That is around 200,000 to 300,000 anesthesia, only one mortality. But the alarming thing is that the anesthesia deaths, human error account for around 65 to 87% of the deaths during anesthesia. And that too, most errors occur, that is around 53%, majority of errors occurring during the administration of anesthesia. That means we human beings, we anesthesiologists, we our technicians, we nurses, our entire anesthesia team is responsible for the majority of the deaths in there during anesthesia. The burden of medication, of everything, we will look for the statistics outside. And it is the eighth leading cause of death in the US, and a huge burden, medical burden also is with them. Indian scenario also, we don't have that much data there, but the reporting, and of course we know, as in any other situation in our country, reporting will be very feeble. Many of the reasons are the medico-legal issues. We are afraid of medico-legal issues and the fear of judgment by the others, by colleagues. We all know the Murphy's Law. The first Murphy Law says that anything that can go wrong will go wrong. And regarding the medical error, another very good law, that is the Murphy's 14th law. That is, if anything can't go wrong on its own, some will make it go wrong. Somebody will be from behind, stab you from behind. That is from none other than some of your colleagues or you yourself will be the culprit of that. So you keep a constant watch and keep alert when vigilant on these factors. There is a model called the SZISACON model, error model. This is wherever there is a safety, we discuss about the SZISACON model. So it's nothing but there is holes there in the SZISACON. If you add on the layers, the chance of the damages will be less. That's a concept. That is one of our triple layer or 4 layer, our face mask and all adopting the same concept there. Likewise, but the problem is that again that also can bypass by the SZISACON. Where safety can also be bypassed, like with the Murphy's first law, that if error can happen, it will happen. So what are the medical errors? Some of the medical errors, the common errors are, we can classify it into mistakes and skill-based errors. The mistakes are the error in planning the action. That can be knowledge-based error or a role-based error. They may have a good rule or guidelines, or still we are not adopting it properly, or we don't have a good rules. And skill-based errors are action-based errors, that's the slips, and memory-based errors are the lapses. Some of the definitions: the medication error, any error in the medication process, and adverse events that may not be related to the medical error and vice versa. And preventable adversible effects are that produces a harm and that could be avoidable by reasonable planning and proper execution. Near miss, this is the occurrence of an error that did not result in a harm. That is very, very important as far as you are being a team leader and you are planning it. You have to find out or pick it up. The near misses are very important because that will help you for avoiding further damages in future. Slips are the action routine behavior being misdirected, and lapses due to the lapse in the memory. Types of medication error, it can be used an active failure, that means unsafe acts are committed by the people who are in the direct contact. That is, the slip and lapses are the skill behaviors, and mistakes the knowledge-based. Latent conditions that is in the future. And again, we can have an error in omission and an error in commission. Error in omission is failure to perform an appropriate action. Commission is an inappropriate action. Factors of medication error: the most important, and you should always remember, these the LASA. That's the look-alike, sound-alike medicines, confusing, inaccurate, and inappropriate drug labeling, swapping of syringes. We are interchanging the syringes, and the labels also we are interchanging, unlabeled syringes and all. And other factors are the lack of staff, overtime and odd working hours, inattention, poor communication, carelessness, and your busy schedule and fatigue. These are some of the LASA examples. You can see the middle one, the midazolam and ketamine, the same, almost same, everything same. Even the top ampoule, everything is same. You can have a phenylephrine, ephedrine and adrenaline, almost same. And again, the phenylephrine and neostigmine, same, all from our India. So we can always expect these LASA drugs. That is again, heparin and midazolam, almost same. Even that is that on the right side, that were a branded company, but almost same. So to categorize the medication error, you can categorize into a error that can have a capacity to error. That means, like the case we have discussed earlier, in the first, a neonate, a infant, that itself is a capacity for an error. There is a possibility there. And in any emergency situation has a capacity for an error. Error of omission, like we are given an instruction for a pre-medication, oral pre-medication a child, but when child come to OT, that that child not given the pre-medication. Like error in commission, that means we are given, we have started when you is a diabetic patient, is an uncontrolled diabetic patient, but without knowing that fact, we have started dextrose normosaline and all. And it's already started, but the problem is that it won't make much of harm. And the temporary harm can also be there. Then the yellow portions are some kind of a harm to the patient is there. We ordered, common mistake nowadays is that the dexmedetomidine and dexamethasone. We ordered for a dexamethasone 1 milligram given a diluted 1 or 2 milligram of dexmedetomidine. And not much damage will happen, but we can expect some bradycardia or hypertension. And temporary harm or prolonged stay can be a damage because you are giving a nerve stimulator or a blind technique of nerve block, supraclavicular nerve block, and accidentally punctured the pleura. Pneumothorax happened. We need to put a chest tube, and patient has to be in a hospital for a few days, at least. The permanent harm can happen, like in a patient having a bleeding tendency, or done a spinal anesthesia or an epidural anesthesia, and epidural hematoma occurred. That it can have a Kodaikon's syndrome or paraplegia or something. And another thing is that sometimes maybe we have to intervene with laminectomy and to evacuate the clots. And in the death, even though it's rare, but that can happen. Like in a post-operative, it's very important. The common mistake is that we have a post-operative epidural infusion. We are ordered for it. And accidentally, they are given a post-op 0.5% of ropivacaine infusion through IV line. And patient can have a cardiac arrest and death. The mistakes are unintentional failures on the planning on action. That can be knowledge-based or rule-based. Prevention, of course, high-quality training, proactive supervision training, and competency assessment. And competency assessment, of course, these are our conference and these kind of topics, discussing on these kind of topics. What are the experience of others, sharing the experience, and everything will help you in the future also. And I take this opportunity to congratulate the scientific committee of SZISACON South Zone 2023 for including this kind of a topic, even though it's boring, especially to the CME program. And these are the BJA some of the recommendations. We will quickly go through some of the recommendations. That's preoperatively we can have a drug history and allergy status, very, very important. We should note down, and weight of the patient, and of course the WHO the surgical safety checklist we all should follow. The minimize the risk of infection. There's a hand hygiene and limit each ampule. That is a vial for a single patient. Swab the top with 70% alcohol, and environment of drug preparation is adequate lighting, and always use a lens. All the times what we use, we have a lens in the OT. But nowadays we don't need, actually we can have a mobile and zoom there. and uncluttered workspace should be tidy and minimal distractions. Preparation, read drug labeling carefully, draw one syringe, one ampule at a time, color-coded syringes, at least we can have some, it's very much available around. And if disrupted, discard. That's the policy. If any confusion of your dilution or something, discard it and put it. Another thing is pre-filled syringes. These are, especially it's available in emergency tray, in emergency situations like. You keep drugs for emergency use in a different routine way and preserve used ampules and syringes in a separate container till the end, and after the surgery you discard it. So this will be useful for the investigation of adverse drug events. Administration, minimize the time between the drawing of drug and administration. Infusion, nowadays the trend is toward the smart pumps and label at the patient, and that is very, very important, especially especially your epidural or continuous nerve blockade or like in IV infusions. There is a high chance of mismatch actually. Of course, another thing is the lubar lock connections also very important. IV, non-IV lines like especially arterial lines and epidural should be labeled and color-coded ones. And after administration, legibly document all these things, discard unused drugs at the end of each case, used control drugs in a separate container, review medications at handover, adverse drug events if there, monitor, manage, and document. Drug prescriptions, we all know some of the major important things are error-prone abbreviations shall not be used. All prescriptions should be on capital letters. That is NABH 5th edition is very strict on that point. And near expiry and high risk medication, you should have a separate caution should be on that side also. And drug prescription, whenever verbal orders we need actually, we can't avoid at that. But whenever it's used should be very cautious. Only in urgent situations. Repeat back and read back. Again, you ask them and even spell it out. Countersigned by the doctor within 24 hours, and electronic medical recording is important. Tallman lettering, that's a LASA, that's a look-alike, sound-alike drugs is a good technique, is a Tallman lettering. That is like dexamethasone and dexmedetomidine. These are the style which this is Tallman lettering system. And the color coding, normal color coding is our muscle relaxant is red, narcotics is blue, and induction agents are yellow, purple is vasopressors, and our anticoagulants is green. Barcoding scanning or radiofrequency IDs, whenever possible use these things. These IDs, these are the newer techniques, and smart infusion pumps technologies for dose error reduction systems. These infusion devices that has a computer embedded within the device, these computers run vendor-specific software that is intended to reduce the dosing error through the use of drugs, specific limits to allowable doses. Very important thing is that it has got a good drug direct library, that is maintaining a good library of standard drugs concentrations. That's induction, what is the concentration for the induction, for the maintenance, what is the concentration, everything there in that drug library. And the problems are costly, and of course, if you have a error possibility is still there, especially the wildcard drugs are using. That drugs that are not in the library is using, there is possibility of error also. The last thing is the culture. That is very, very important thing as far as drug error prevention is your institution is concerned. Non-punitive system for reporting, written policies for medication safety, training of existing and new staff members. Whenever a new staff member come to your team, always train them, and adequate supervision. And the role of pharmacist in the sense is that LASA, the first person to screen the LASA is the pharmacist. Actually, there is a look-alike, sound-alike drug. It's the first responsibility is the pharmacist to avoid that kind of a drugs, of course. Because the problem is that if you are procuring the drug into your pharmacy and the drug come to your OT, you don't have any choice to avoid it. So to summarize, the 5 rights of medications are the right patient, right drug, right dose, right time, and right route. So again, out to our iceberg tip. Error death is only the reporting error and is only the tip of the iceberg. unreported are the majority. So last word, simple vigilance. In our even our ISA logo denotes that the eternal vigilance, standardized protocol training and simulation, and safety first, think before you act. And I will conclude in a minute with a last story on 10 years back. We had an incident. The patient has, when I come to OT, our OT will start around exactly on 8 o'clock in the morning. When I reached in the parking lot, I got a call from our preoperative sister that's come fast, I made a mistake, I have given a wrong drug. Patient in a distress. I came to OT, I rushed into the pre-op room. That she said that instead of, that is a FES, that is a functional endoscopic sinus surgery for local, under local they are doing. And for some bleeding prevention medicines, instead of that she has given atracurium, 25 milligram to 50 kg boy, given atracurium. And fortunately, what happened is that our technicians, everyone, they bag and mask ventilator, and I put in a supraglottic device. And if once diagnosed, it is very easy for us to manage because this is our everyday job. But the thing is that the surgeon, I could still feel the cold extremity grip of the surgeon on that. Sir, what will I say to the bystander that it is under local anesthesia, this patient shifted to ICU and all. But within an hour we will manage everything, and within 1 or 2 hours patient is removed the supraglottic devices and send the patient to home. And I myself explained to the relatives that we are given a drug, drug allergy patient on some kind of a drug. He has got a drug allergy, and we will do the surgery on the next week. Everything went smooth actually. And so the thing is that our colleagues may be doing a big harm to us, but the problem is that don't blame them, because your attitude should be, and you could be non-punitive. Only then they will report to you their mistakes. If you can manage your airway, and if you have good books to follow, and then enjoy your anesthesia with a cup of coffee, and have a safe anesthesia in your bright future. Thank you.